I'm Chelsea McCurry. I'm the educator for CVICU and CCU. I'm going to go over Swan insertion. If you're having to do this at bedside, you want to gather all of your supplies. Just go down your list and make sure you've got everything you need. You're going to want to get whatever you can set up ahead of time. Go ahead and have the ultrasound in the room and set up your pressure lines. If you have the triple pressure line that will have your CVP, PA, and ART line all in one, that's awesome. Sometimes those are out of stock and you have to just use 2 pressure lines. So you just have to have at least 2 because those are going to go to your PA and your CVP on your Swan. Go ahead and get them spiked and as much air out of the lines as you can. And then before the Swan is inserted, we're also going to flush and prime the Swan. Our patient today has already had his sheath put in, but if that part is done before your Swan insertion, you're going to want, it's going to be similar to a central line setup. It's basically the same procedure except it's a little bit bigger of a device. So you're either going to use a sheath or a cordis to have this Swan go through. So he's already got his sheath, got the cardiology fellow here, and he's going to help us put the Swan in.
So my name is Elias Lynch, one of the cardiologist fellow here. So at this point, we just need to insert the Swan in. So usually over here, if you can help us while we're getting this access secured, make sure the balloon is working and it's not defective. So this syringe is preset at 1.5 cc, so you can't pull more than that. Usually I check it without any air. And over here, this is our balloon port. And you open it to the patient, inflate, deflate first, make sure there's nothing, and then close it back, inflate. And then this time you inflate, you check the balloon, you see the balloon coming up, and then if you're going to keep it up, you have to close it and then unhook it. But usually don't unhook it, just keep it on it, and then that way you can just put it back. Okay. So now we know we have 1.5 cc of air. It's ready. When we advance, we want the balloon deflate initially till we see our pressure that we are in the RA, and then we'll ask you if you can inflate the balloon, which means you open the port for us here, and then like if Chelsea wants to do this, not yet.
Sorry.
So.
And for them to see the pressures as they're inserting the Swan, you want to make sure that you've got your pressure line zeroed and ready, and have it pulled up on the monitor for them so they can see the numbers as they're inserting.
So once we put it in, we're monitoring the monitor over here, and then once we tell it, hey Chelsea, please inflate the balloon, go ahead and inflate, we inflate, and we close the port immediately so the air doesn't come back, because we don't have x-ray we're not looking on the floor to see if the balloon went down, so that'll make sure to help us with that. And then we just advance slowly. At that time you just don't have to do anything, just let go. Put it on the sterile field and go from there. Anything else at this moment?
The nurse should also just be ready to take down the pressures as the physician is calling them out. Normally I like to have someone else in the room with me if they're available, and as he's calling out right atrium or RA, they want to record that pressure, the RV pressure, pulmonary wedge pressure, and then the pulmonary artery pressure.
Yeah, and most people will take multiple saturation along the line, or they do it backward. It depends on the preference. This is a lead-in Swan, so most likely we'll take like RA pressure, and then RV pressure, and then PA sat as well. Sat saturation. So we take an RA saturation, RV saturation, and then PA saturation.
And for that, the respiratory therapist will hopefully be there with you guys and be able to run those samples for you on your co-ox machine. There's one located in CVICU or in the cath lab.
Yeah, and then this is for the PA saturation, is this one, and for you don't have to do this one, but usually you do the RA pressure, the RA sat from this one, if you want, mixed venous.
This is your Swan catheter. I'm just going to walk you guys through the main pieces and then talk to you about how you would take care of it after it was inserted. The very tip of the catheter should sit inside of your pulmonary artery. Typically this is going to be verified on x-ray. The very tip is your pulmonary artery pressure. This is going to be your yellow waveform on your monitor, and because we like everything color coordinated, it's your yellow port here as well. Your waveform should look similar to an arterial waveform, but it's going to be a much lower pressure than a systemic arterial pressure. It's going to be just coming from that right side of the heart. This is also where you would pull your mixed venous or coax from. It's the most deoxygenated blood in the body. So as the body's used all the oxygen and it's returning to the heart, it goes through the right atrium, the right ventricle, and then into the pulmonary artery. So when you pull that blood and you run your coax, it gives you a percentage of oxygen left and tells us about the supply and demand of the body and heart. As you move back on your catheter, the next hole that's right at the 30 centimeter mark is going to be your CVP. It sits right about at the right atrium of the heart. This gives your central venous pressure on your monitor. It'll be a blue waveform and color coordinated again. It's going to be your blue port on the end of your Swan. The balloon sits at the very tip. It comes with a safety syringe in your Swan kit. It will not pull back past your 1.5 mark. To inflate the balloon, you'll attach the syringe, open the port. The port is open when the arrow is complete. It's locked when it's not. So you've got your open port, your arrow is complete, and you can inflate your balloon. The times that this will be inflated is during insertion. As they go into the right atrium, they inflate the balloon, and it works kind of like the sail on a ship and pulls the Swan catheter into place. Once they've got it into place, they'll look for it to wedge in the pulmonary artery, and then you'll deflate your balloon and the wedge you'll go into a pulmonary artery pressure. It will no longer be wedged. The balloon should not be left inflated. If the provider wants a wedge pressure, they will come and wedge the Swan themselves. The nurses at Erlanger should not be wedging a Swan. Typically, just to make sure that this doesn't accidentally get wedged or inflated, I will make sure that all of the air is out of my balloon, lock it, remove the syringe, and just keep it in my room so that if they need to wedge, the safety syringe is available, but it's not going to get turned and accidentally inflated behind your patient. Before insertion, you're going to make sure all of this is primed and ready. They will be on a sterile field, but you'll have your pressure lines here and ready, and you'll connect the pressure lines. Typically, they're going to be sterile holding this, and you'll be holding your pressure line. And you'll do the same thing for your PA pressure. They'll have their Swan on the sterile field. And as you're flushing these, they're going to be looking for the saline to be exiting on the Swan. Really important to make sure you're giving another look over your lines and making sure you've removed all the air. They'll place the sheath, and another important piece that is often forgotten is the sterile sleeve. So make sure that this is dropped onto their sterile field, and this goes on the Swan before insertion. It's called a cath guard in your Pyxis, and I know they're in the CV's Pyxis if you have trouble finding them. But this will be threaded over the Swan, and what this allows is for them to have a sterile sleeve, so if they need to reposition the Swan, they can. On your Swan, you have measurement dashes. The smaller fine dashes are 10 centimeter markings, so 10, 20, and then once you get to 50, it'll be a boulder line. So if your patient was sitting, their sheath was sitting about here, this would be a bold line and a skinny line, so we know that's 60, and we're about halfway in between, so we would say our Swan's at about 55. So after our swan's been inserted, one thing we're going to want to do is shoot numbers. Typically they're done right after insertion and then at least every 4 hours with your assessments or as ordered. One thing they may want is numbers after you've made changes in some drips. But to get ourselves set up for shooting numbers, we'll need our temp probe. These look a little different than your regular temp probes. This has the connector that'll go to the Swan, and then it has a probe that'll sit in sterile saline at room temperature. So to connect, this port we haven't talked about yet is going to be your temp port. And you're just going to line it up. So there's an arrow on the Swan, and there's a line on your cable. You just want to line those up. It's important to make sure you're not trying to force it. There's tiny little wires inside. If you force it, you can break those and your Swan's no good and you're not going to be able to shoot numbers. So just be careful while you're doing this part. You'll twist to lock it, and this will plug into your monitor. And this will plug into your monitor. So you've got 2 temperature readings now that you've got yourself hooked up. One of room temperature saline, one of the patient's body temperature. What this allows is for us to do a calculation using thermodilution to get cardiac output. We'll take 10 cc's of room temperature saline, inject it into the patient at the right atrium, so using your CVP line, and the time it takes for the patient to change temperatures, to cool down with that injection of saline and then come back to their normal body temperature, there's a calculation that your monitor will do to give you a cardiac output. Alright, so let's set up for our CVP. When you're ready to shoot numbers, you're going to need a couple of supplies for that. You'll need another bag of sodium, just a bag of normal saline, straight IV tubing, a 10 cc syringe, and a 3-way stopcock. We're going to just prime our IV tubing like we normally would. So you can go ahead and attach your stopcock to the end of your saline. Your syringe will go on the other side. And then you want to go ahead and prime that stopcock. Really important to minimize air as much as you can when you're dealing with your Swan. And this is going to attach to your CVP. Wherever this is pointing is where it's off to. So when you're ready, you'll pull up 10 cc's of saline, and then you're going to open this to the patient, turn it off to your pressure bag, and in a rapid, smooth motion, you're going to inject your 10 cc's of saline. I'm going to go over the computer side of that. So before you're ready to inject your saline, you'll come over to your monitor and go under Procedures, Cardiac Output. It'll say Ready for Injection when the monitor is ready for you to go ahead and inject the saline. So just wait for it to say that, inject your saline. You'll see a curve on your screen, and it'll give you your first number, your first cardiac output. Typically you want to do this 3 times. If you have one that is got a bad waveform or is pretty far off from your other 2, you can take that one out. You would just go into Edit Average and deselect the one that doesn't look good. When you're ready to get the information from the monitor, you'll go into Calculations. This is where you'll see your cardiac output index, stroke volume, and SVR. Those are going to be the primary numbers that you're looking for to document. One thing to check while you're in this screen is to make sure that your heart rate, your map from your art line, and CVP are all correct. It uses those in the calculation, so just making sure that the line wasn't clamped or something when it took that measurement. Under demographics is where you can enter your patient's age, height, and weight. If you're not getting a cardiac index after you've shot your numbers, this is the first place you can troubleshoot. Just make sure that their height and weight is in there correctly. If it's not, it doesn't have a body surface area to calculate your cardiac index. One thing that's really important is to make sure that you're maintaining patency in your sheath. So you have this sidearm. Sometimes it'll just be clamped and have a cap on it. Sometimes it will come over from cath lab with heparin going to it. It's okay just to switch that out to normal saline and just keep it flowing through there. The other option is you can switch this to an IV pump and have normal saline going to it, just KVO fluids. If the patient's on medications, you can move your medications to the sheath as well. But you just need to keep something running to that line to maintain patency. Per Erlanger Hospital policy, an RN can remove your Swan from your patient as long as you have an MD order. It's going to be similar to removing a central line. You're going to put the patient on their head a little bit, ask them to turn their face away from the site, clean it really good, and then we just have a couple of differences. We're going to want to make sure that the pressure lines are depressurized, so either let the air out of your bags or turn it off to the patient. And you're going to want to make sure there's no air in your balloon. You should not be removing a Swan with any air in the balloon. So I'm just verifying there's no air in my balloon. And then in one smooth motion, you're going to pull the Swan out of the patient. Remember that you're coming through the patient's right heart. They're going to, just having this in place puts them at risk of arrhythmias, but especially during removal, you're going to be coming back through that right ventricle. Don't stop, pause, because you could be irritating the inside of their heart. So just swift motion out, and then it's over. You can leave the sheath in place if they still have medications that need central access. The only thing you'll need to do is cap it. These caps can be found in the CV Supply Pyxis. I'm not 100% sure where else you can find them, but these will just go over your sheath, make sure it remains sterile, and reduce your risk of air entering the sheath. If you have an order to draw a coax, make sure you're communicating with your respiratory therapist. They will be the one that will actually run the sample. There's a coax machine located in the CVICU or in the cath lab. When you're ready to pull that sample, you're going to be pulling it from that yellow port, your PA port. You want to make sure you're using a heparinized syringe. Those are located in the art line or arterial stick kits, or we have the individual heparinized syringes that your respiratory therapist can get for you as well. The reason it has to be heparinized is it has a very fine needle that is on the coax machine and it easily clots, so it's really important you use those. We've had a lot of issues where those out of order because the machine is clotted up from not using a heparinized syringe. You just need a couple cc's of blood, so just like you would, go ahead and attach your syringe, turn it off towards your pressure line, pull back 2 or 3 cc's in your heparinized syringe, back off to your syringe. You'll hand this off with a sticker to your respiratory therapist and they can run the sample for you. You're going to want to flush using your pressure bag setup. You don't want any hard, fast flushes going through your pulmonary artery. You also would never give medications through your pulmonary artery line. It is okay to give medications through your CVP line, but you would never do it through your pulmonary artery line. Some complications that you can have from having a Swan in place: it is a foreign device going through their heart and into the pulmonary artery. So having that foreign device inside of their heart can cause atrial or ventricular arrhythmias. Something else you want to be mindful of is infection. So maintaining a good dressing over your site can help, but just having that place puts them at risk for infection. You can also have clot form because it is a foreign device in their body, and then any air introduction could cause a pulmonary infarct. The worst complication that you can have is a pulmonary artery rupture. It would be coughing, lots of blood, or if they're intubated, blood being sucked out of their ET tube. It is a very big emergency. So if you have a patient that has a Swan in and you're starting to have new bleeding when they're coughing, or if you're seeing it in their ET tube, make sure you're calling your provider right away. If they're not intubated, they will be getting intubated and going to the OR as fast as you can.